All this is Dr. Mubin Sayed from drbeen.com. Welcome to one more show. And today we are going to talk about something that I have been getting a lots of comments about. And that is the dose for vitamin D and what should be the accompanying dose for vitamin K or calcium. So that is the discussion that we are going to do today. So welcome to the show. Let's start our discussion. So here I have a few links and a few tabs open here. These tabs are present. The links are present in the description as well. Welcome everyone. So this is from Harvard. And what I wanted to take from here was to put this, this is for vitamin D. To put this into perspective, 4 ounces of cooked salmon contains approximately 600 international unit of vitamin D. So we're going to talk about how much vitamin D is necessary, but I thought this was an interesting thing that how much salmon contains how much vitamin D. Then here, we're going to talk about this as well, Coimbra Protocol. So Coimbra Protocol, he is a Dr. Cicero Coimbra. He is a neurologist. So James Kelly, who is a good friend from Canada, he had sent this over to me to look into, and he has helped today with the discussion. So hello everyone. Hello Margaret. Hello Michael. I wanted to make sure that we look at the Coimbra Protocol as well, which is a high vitamin D dose administration for some serious diseases like Parkinsonism and multiple sclerosis and so on. Then there are some links over here that are about what is cholecalciferol. And I have done the discussions about vitamin D many times. Today, I'm not going to go into the functions of vitamin D. Instead, today I'm going to talk about the dosage variations that various people have tried, and the accompanying dosage for vitamin K2 and the calcium. So today is all about dosage. And the disclaimer, this is not a prescription for any of us. This is just an educational material to assess and explore what various doctors have been prescribing to their patients. So this is about Ergocalciferol, that is the vitamin D present in the plants, so called vitamin D2. This is something that is really important. I have this link in the description, so please make sure that you look at this one. This is also sent by James Kelly. And here the basic gist of this all is that instead of 600 to 800 international units of vitamin D every day, it seems like 8,800 international units per day is the right number. So that is a discussion here and the reason for why they think that is the way. This is another link which is really important. In this link, what they have discussed is what is the comparative dosage of vitamin D, for example, Ergocalciferol or Cholecalciferol or vitamin D3 and D2 that we find in either in our skin or from food versus Calcifediol, which is the second stage of the vitamin D and in our body. And I'm going to discuss that in detail. And they've compared them. So we're going to talk about this as well. This is really an important article. Here, this is one more, and that is this is the importance of body weight. So I wanted to make sure that we can look at the vitamin D dose with the body weight. So various body weights or BMI levels may need varying levels of vitamin D. So we'll talk about that as well. Then there is this vitamin K2 or the vitamin K's flavor that needs to be accompanied with the vitamin D. So we'll talk about this one and its dosage. Here is again the dose recommendation. I have a Amazon's supplement bottle here as well, just to show. Then over here, this is about the reference intake for vitamin A, vitamin K, arsenic, and others. So we'll talk about that too. And finally, for calcium, what are various dosages and stuff. So this is the basic links that are present. And let us start now our discussion. So look, we'll start from vitamin D. The takeaway for today is the following. One, we should become clear that what is the vitamin D level that we can take daily, number one. Number two, what form of vitamin D is important for us to take? Is it cholecalciferol or the normal supplement, which is called vitamin D3? Or is it the calcifediol, which is the second stage of vitamin, or it is calcitriol? So that is the second part. Third part is we have to see that which body weight will require how much vitamin D. Then the fourth takeaway is with the vitamin D, how much K2 should be taken and how much calcium should be taken. So that is a discussion. So it's all about dosage. So look at this. Vitamin D, the very first stage that we can eat from in food, for example, salmon, or the vitamin D that is formed in our skin by the UVB light, and I have discussed that in the past, or the vitamin D that is in vegetable, for example, mushrooms, or the vitamin D that is in the fortified foods. All of those vitamin Ds that we can take from outside, vitamin D3 or D2, are the primary intake source or production source in the skin. From there, we also know that that vitamin that we eat will then go to, from a GIT, it will go to our liver. And liver, from GIT or from skin, it goes to liver. Liver hydroxylizes it or changes it, and it becomes calcidiol or calcifediol. So this is what I call the second stage of vitamin D metabolism. It is still not the active stage. Then the kidney or some other cells as well can then take up this calcifediol or the second stage of vitamin D and then convert that to calcitriol or the third and final stage of vitamin D, which is the active form. So the takeaway today is going to be how much to take this one, or are there people amongst us who need to take the second stage instead of the first one, or are there people who need the third stage as well? So that is a discussion. So let's start. Here what we are talking about is this is the vitamin D3 and D2, the first stage. The recommended daily allowance. So today what I'm going to do is I'm going to show you the dose that is recommended, and then I'm going to show you the dosage that various doctors have used in higher doses of vitamin D and what kind of safety margins they've seen and what kind of therapeutic outcomes they've seen. So the regular normal dose or daily allowance, recommended allowance from in the US, 600 international units per day for vitamin D3. In Europe, 800 international units per day. In France, 1,000 international units per day. So that is the recommended daily allowance. This paper that I showed you here, this paper claims that the calculation of the RDA is incorrect and the correct daily intake should be 8,800 international units. So I have put that over here as well, that the corrected RDA by those authors is 8,800 international units per day. Now, question is, should we take this form of vitamin or should we take calcifediol? So it's a very simple thing. Look, the first form of vitamin or inactive vitamin has to go to liver by getting absorbed from our GIT or coming from the skin and then become converted to the second stage. So if there is a problem with the skin conversion, what does that mean? Maybe we are tan in our color. Maybe we use a lot of sunscreen. Maybe we do not have enough sun. So whatever is the reason, if our skin, or maybe it is winter, a cold time, and we are wrapped up and bundled up in clothes all the time. So whatever is the reason, if our skin doesn't have a chance to make lots of vitamin D, then we need to figure out an active form, or we need to take the supplements. So if we take supplements, then the second issue that we have to figure out is that is our intestine, gastrointestinal system, is a GIT correctly absorbing the vitamin D or not? So those folks who have an issue with the skin making vitamin D, or have a GIT issue that they have a malabsorption problem with the GIT, or whose liver isn't working correctly. In all these cases, the second form of vitamin D or the calcifediol is given, because the first form cannot get converted to second form, because either the first form is not made, or if it is eaten, it is not absorbed, or if it is absorbed and goes to liver, then the liver is not metabolizing it or converting it correctly because liver has a problem. So in that case, the second stage, and that is by by prescription. Now if we have, let's say, kidney issues, let's say we have a chronic kidney disease which causes the kidney not to function correctly and convert the second form to the third form not correctly, then the third form will have to be given. So I hope this becomes clear that who is a candidate for the supplements. Most or all of the healthy individuals will be candidate for supplements. Those individuals those individuals with the skin issues, or with the sunlight issues, with their daily lifestyle, or with GIT issues, or with liver issues, they may need to go to calcifediol. And it is by prescription only, at least in the US. If individuals have kidney issues, then they'll have to go to, once again, prescription with calcitriol. Now, going back to the dosage, 600 and 800 and 1000, corrected according to some authors is 8800. Then let's look at the high dose. There are doctors who have been giving 5000 international units per day or 10,000 international units per day, and I'll show you doctors who are giving 100,000 to 300,000 international units per day. So high dose is very common as well. In my own practice, I use, for COVID-19 time, nowadays I use 5,000 international units per day on a regular basis. The toxicity has been observed to be at 50,000 or more international units per day if vitamin D is taken for more than 2 months. Now, so this is the second level. So this was RDA. Here is a little higher dose. This is my recommendation. Then even higher dose. So for that, the Coimbra Protocol that I showed here, Dr. Coimbra, he is here. So they have been using vitamin D from 10,000 international unit to up to 300,000 international units per day. So that is a lot of vitamin D. So I see a question here. Lorette Dillon says, oops, is the active form IV for D3? So the active form of vitamin D can be oral or injectable, but vitamin D3 or D2 is usually oral, and that is the supplements that we usually get. Okay, so back here. So even up to 300,000 international units per day, and he is a neurologist, so he has been treating multiple sclerosis, Parkinsonism, and other diseases with high dose of vitamin D. So it would be interesting if you can look into that protocol as well. I tried to read it, but that was all in Spanish, so I could not. Then BMI based dose adjustment. So let's say that if your BMI, if you have some extra weight, then how much vitamin D should you take? So normal BMI, which is usually between 18.5 to lesser than 25, these numbers that I showed above are for the normal BMI. So that is again 600, 800, 1000. Or let's say 5,000 nowadays for a few months per day, international units. If the BMI is overweight BMI, that is the range is 25 to lesser than 30, then the recommended change in vitamin D levels or intake is 1.5 times that of regular. So if a person in normal BMI range is going to take, let's say, 5,000 international units, then a person who is overweight will have to take 5,000 multiplied by 1.5, that is 7,500 international units per day. Then if somebody is obese, then they may need to have 2 to 3 times the vitamin D. So for that means that, let's say 5,000 is international units is regular for one day, then 10,000 to 15,000 international units per day for somebody who is obese. And what is the reason for that? There is an important thing to notice, and that is, so I'm going to draw it here. As the vitamin D appears in our body from various sources, that may be the skin, that may be plants or fish, etc. So food or skin. So as the vitamin D enters our body, it will go to our fat cells. So fat cells will act like a container or a depot to store this vitamin D that just arrived. So let's say this vitamin D is going to be stored in the fats. Then what happens is that our liver on a daily basis is going to pull the required amount of vitamin D, convert that to calcifediol or calcidiol, and then give it to the body. So vitamin D will be stored in the fats. So if somebody has a lots of fat cells, then they would store more vitamin D in them, so their general requirement increases. So back here then, for obese folks, 2 to 3 times the normal RDA. For overweight, 1.5 times the normal RDA. Then there is another link that was sent today by James Kelly once again, and that was about the vitamin D hammer. So vitamin D hammer here, so this is what is their vitamin D hammer. And what they do in that is, for their patients, they either give 50,000 international units stat, so one time 50,000 international units, then regular RDA, or they give 10,000 international units thrice daily, so that means 30,000 international units in a day, and then for 2 to 3 days, and then regular. I know that one of my family members, they were having age 60, 62. They had lots of muscle pains and fatigue, and could not walk because of the pains in feet and etc. So the doctor who saw her, he gave her 200,000 international units at one time, and then he put them on a weekly, I believe, 100,000 international units. So it seems high, but she has been since very, very fine. She doesn't have those complaints anymore. So high levels of vitamin D have been used, and so this is another example of using high levels of vitamin D. Now, some quick math. So before I go to math, that is more discussion, more detailed discussion of vitamin D dosage, I want to go to the accompanying vitamin K2 and vitamin and calcium. So let's look at it. So when we are taking vitamin D, it is important to take vitamin K with that too, and especially K2. The reason for that is that when vitamin D is taken, vitamin D's function is to mobilize calcium, and mostly it would deposit that in the bone. However, it's going to look at phosphate and calcium levels in the blood. And if for some reason it doesn't have the right calcium, it's going to increase that calcium in the blood by increasing the absorption and by increasing the reabsorption from the kidney, and by mobilizing it from or depositing it into the bone. So there is a complex mechanism. I've discussed it before. End result is there is calcium in the blood. Now, if that calcium is not appropriately routed to bones, then that calcium is going to start getting stored in soft tissue, for example, blood vessels and kidney. In the kidney, it can cause kidney disease, it can cause stones, and eventually kidney failure. In the blood vessels, when it would be deposited there, it would cause atherosclerosis and eventually hypertension and heart failure. And these are just a couple of things that extra calcium can do. There can be other issues as well. So what we do is we need vitamin K2. K2's function is to actually activate those proteins that would help remove calcium from the soft tissue and help them be deposited in the bones. So it is necessary that when we are taking vitamin D, especially if in the higher doses and for a prolonged period of time, we have to take vitamin K2 so that our kidney and our blood vessels are not unnecessarily calcified or develop stones in them. So for that, the vitamin K2, 1000 international unit of vitamin A and D should accompany it. So 1000 IU of vitamin A and vitamin D should accompany. So there are two types of vitamin K2s. One is called MK7, and that is a long chain vitamin K2. And the other one is called MK4, that is a short chain vitamin K2. MK7 is more potent, so 100 microgram of vitamin K2 MK7 form every day. Or if it is going to be MK4 form, then 1000 microgram every day. So if you see here, I have if you look at this one, this is most active form of vitamin K2, MK7. Again, I have nothing to do with this brand. I just opened up Amazon and searched for vitamin K2. So nothing, I do not even know who they are. But if you look at their daily allowance, if you see here, they are saying vitamin K2, MK7 form or menaquinone 7, 90 microgram, 80% of daily recommended value. So in the US, since 2020's beginning, we have been using the abbreviation or the metric daily value instead of RDA or elemental. So what it is saying is that the daily value, 80% of the daily value is present in one serving size, and maybe one serving here is one soft gel. So if you see here, it says serving size, one soft gel, serving per container, so total 60 gels in there, and one soft gel has 80% of the daily value present in it. So that is how we would look at the vitamin K2. So vitamin K2, I would not increase the vitamin K2 with vitamin D. For example, if we are taking 5,000 international units, I would not recommend that we go and take 500 microgram of vitamin K2. I would stop it at 100 microgram. Now, please remember that vitamin K is in three forms: vitamin K1, K2, and K3. K1 is much more active for coagulation and clotting. K2 is much more active with the calcium type metabolism, but it is also important for clotting or used in there. K1 can be converted to K2 as well. So those people who are using vitamin K based anticoagulants, they should not take extra vitamin K without asking their doctors. So patients on vitamin K antagonist for anticoagulation should not take vitamin K. So please be careful if you are taking blood thinners. Talk with your doctor first. And that means if you're not going to start vitamin K2, then also don't start high dose of vitamin D without talking with your doctor. Correct. So there is a comment here by Mary. Remember that vitamin K clots, so works against comodine or warfarin. So that is exactly what I'm talking about. I didn't want to name the drugs itself, but if you're taking any K antagonist, then please don't take more K, because you're already taking drugs that are blocking the vitamin K. Taking more K would actually cause coagulation, which can then cause the problems. For example, strokes or heart attacks and so on. And finally, calcium. So calcium's recommended daily allowance is 1000 to 2000 milligram. And I'll show you a table here. And I have this link in the description as well. So here you can see table 19 to 15 years, 1000 milligram, daily upper limit is 2500 and so on. So you have this table over here. Now, the important thing to keep in mind is that calcium, it can also become dangerous, especially extra calcium present can cause kidney disease, or aggravate the kidney disease. Extra calcium can cause, if it is too much extra, then it can cause constipation, fatigue, lethargy, nausea, vomiting. Extra calcium can cause cardiac arrhythmias as well. So if you are a heart patient and you're taking drugs for heart, maybe you're even taking calcium channel blockers, in that case, taking calcium can become really, really bad. So make sure that you do not take calcium without talking with your doctor. Now, if you're not going to take calcium, that means you're not going to take vitamin K2 extra. That means you're not going to take vitamin D extra. So if there is any such reason, for example, kidney disease or cardiac issues or other hyperparathyroidism, so if there is a condition like that, then all of these supplements will have to be first discussed with your doctors and then taken. Right, so calcium RDAs are those. Now, one more thing for the calcium RDAs. There is a couple of things here: recommended daily allowance, elemental calcium, and then daily value. They're all kind of different things. In the US now, from 2020, we have started talking about daily value. So if you see here, this is a calcium 500 milligram. And if you see here how it says on its label, amount per serving, percent daily value. So vitamin D, so it is D and calcium together, 400, 400 international units or 100%, which I doubt that is really the daily value. But anyways, that's the thinking about. Calcium, 500 milligram or 50% of the daily value. And so they are assuming that daily value is 1000 milligram, and that can change based on the person's need and age and their height and their body weight and their kidney status and their hypertension status and cardiac tissue status and so on. But this is what they have. So please realize that daily value is just a percentage number of the recommended dose. So I hope that is clear. So here, if you wanted to just know the doses, you can stop here. So 5,000 international units of vitamin D, then with that 100 microgram of, let's say, vitamin K2, MK7 form, and then with that about 1,000 milligrams of calcium. With this, now I'm going to go into a little bit more depth. So whoever wants to stay around, please do. And that is some math with vitamin D. So 40 international units of cholecalciferol, that is the vitamin D coming from the vitamin D3 coming from the fish or from our skin, is 1 microgram of cholecalciferol. So 1 microgram is called 40 international units. 4,000 international units per day for 3 months, when given, usually create the plasma level of 40 nanogram per milliliter of calcifediol. So remember this, please, that when we administer vitamin D, when we administer this D, the measurement is done on this stage. So we do not measure this in the blood. Instead, once it has become converted into the second stage, it is the second stage that is measured. So back here, 4,000 international units, when given for about 3 months, they bring the plasma levels to 40 nanogram per milliliter. And normally from 30 to 50 nanogram per milliliter is supposed to be normal. But if you would see, for example, Coimbra Protocol, they can go up to higher numbers, 200 or 300 nanogram per milliliter as well. 100,000 international units given stat, that means given once, can produce, so please realize this is very important, within 7 days. So liver can take up to 7 days to metabolize the vitamin D that we have taken. That vitamin D actually goes into the fat storage, then liver keeps pulling it out of there and keeps metabolizing or activating it to the second form. So if we give 100,000 international units stat, that means if I get 100,000 today, now, within 7 days or after 7 days, I will develop 42 nanogram per milliliter of the calcifediol levels. and onwards. So that means if I am not sure that what is my level at this time, but I want to make sure that winter is coming, I want to be healthier, and I haven't gotten my test done, then possibly 50,000 to 100,000 one time would give me at least a chance to come into the normal range. Then after 7 days, liver is still going to continue to pull more vitamin D. This 100,000 has gone and stored in the fats. Then it would continue to pull more vitamin D from there and continue to metabolize and provide from anywhere from 42 nanogram per milliliter to up to, on the lower side, 39 nanogram per milliliter on daily basis for 70 days. So 100,000 units given now can help a person stay in the normal range for up to 70 days. Again, this means that the person has a correct absorbing GIT, the person has a correct liver, is not obese, is not overweight. So all those parameters have to be taken into account, but this is for a healthy individual. Then, and my own anecdote over here, the patient that I had checked who had cancer as a comorbidity and was deteriorating very fast with COVID-19, I had given him 200,000 international units stat, and then I maintained them further. So 100,000 international units here. Half-life, so this is also a very important point here. Half-life means the amount of time in which the plasma levels of some drug drop to half. Cholecalciferol, that means from outside when we give vitamin or from skin, when that is given, the half-life is up to 2 months. And the reason once again is the same. The vitamin would go, get stored in the fatty tissue. From there, liver would continue to pull it out and metabolize and make it available for the body. So up to 2 months, it would be stored and used. So that is, it would become half every 2 months. Calcifediol, that is the second stage of the vitamin D, which is after the hydroxylation that happens in the liver. This has 2 weeks half-life. So if you're giving calcifediol because a person has GIT issues, or they have liver issues, or they have skin, for example, tan, or they're living in a place where there is less sun, etc., then if you're giving them calcifediol, then it would stay consistent, or half-life is 2 weeks. The reason for that is cholecalciferol is much more lipophilic. It likes the fats and attaches to them much better than calcifediol. Some more information here. So there are some metrics you would see: nanogram per milliliter versus nanomole per liter. So when you see nanogram per milliliter, so here is the conversion. If you multiply nanogram per milliliter with 2.5, that would give you nanomole per liter. So for example, 50 nanogram per milliliter is 125 nanomole per liter. Then there is a article here, which is, I think, is very important for dosage. And that is, I believe this is the one. This is the one. So here, what they have discussed it, if you see here on average serum levels, this part is what I'm going to discuss now. What they say is, if somebody is getting up to 1,000 international units of vitamin D every day, so that means 400 or 600 or 800 or up to 1,000, then their plasma calcidiol level increases by 4.8 nanogram per milliliter per day. So, or as long as they're taking it. And then there is an upper range. After that, it would stop becoming higher. It would just then start persisting. So 12 nanomole per liter or 4.8 nanogram per milliliter can be the increment per 1,000 units given daily. If, on the other hand, a person is given 15,000 to 20,000 units daily, then their plasma levels will increase by 1.1 nanomole per liter per 1,000 units. So, for example, if you're giving them 15,000 international units, then they would increase by 6.6 nanogram per milliliter or 16.5 nanomole per liter. So that is a bit of the discussion with the dosage. I hope that that helps. This was a very common question that I had been receiving, that what should be the dose of vitamin D and what should be the dose accompanying with vitamin D for vitamin K2 and the calcium. So I hope that that makes sense. I hope you're all fine. Tomorrow is my off. I'll see you on Monday. And once again, thank you to everyone who has been donating and supporting this work. Please like, subscribe, and share. And I'll see you on Monday. The good news, on Monday, we'll have Dr. Herrera with us, who is making the rapid test kit for COVID-19, which does not need machines, and that can be used in a point of care or at home. So we're going to ask him, how is that going? And secondly, on Tuesday, we'll have Dr. Paul Marek with us of Math Plus Protocol once more with us, and we are going to discuss some more things. So I had a long discussion with him today. We talked about what are the things that he is seeing that doctors are not aware of, and he would like to discuss those. For example, the phases of the disease and what phase should be managed in what way, and then secondly, the mask, etc. So we'll have him with us on Tuesday. I'm super excited about it. So thank you very much. See you next week. Bye-bye.